Again, this week's lecture is going to be on hypertension. Um, so let's look at some of the epidemiology of hypertension. We say hypertension affects about 1 billion people worldwide. So it's extremely common. It is something that, you know, in terms of the diagnosing and treating, everybody should be comfortable in doing that. Among people 50 and older, what we call isolated systolic hypertension is the most common type. So the older you get, the systolic blood pressure tends to go higher. And systolic blood pressure becomes more important than diastolic blood pressure as an independent risk predictor for coronary events. That is, for blockage of the blood vessel around the heart, systolic, that is the top number, becomes more important for that. Also, it is more important for individuals who get stroke, heart failure, and end-stage renal disease. Um, Clinical trials, studies have shown that the treatment of blood pressure reduces cardiovascular disease outcomes. So if you treat blood pressure and you get the blood pressure down, it reduces the death and morbidity related to cardiovascular disease, including stroke, myocardial infarction, that's heart attack, and heart failure. So one of the landmark study was the Framingham Heart Study, where they use a whole community and follow these patients over time. So if you look at hypertension as a risk factor for cardiovascular disease, uh, and you look at what we call normotensive patients and hypertensive patients, so patients without blood hypertension and in patients with hypertension. If you look at coronary heart disease, blockage of the blood vessel around the heart, you can see in male having hypertension, having high blood pressure, increases the risk for coronary heart disease. Okay, and then for stroke, you see the same thing for male and female. Having hypertension increases the risk. Um, so, and then for peripheral artery disease, blockage of the blood vessel in the legs, the same thing. Having high blood pressure increases the risk for peripheral artery disease. And similarly, in heart failure, patients who develop heart failure tend to have more hypertension. Um, when we look at cardiovascular mortality, the death uh, from cardiovascular mortality, that is heart attacks, strokes, the likes, the risk doubles for each blood pressure increase of 20 over 10. So systolic increase of 20, diastolic 10 increment. So as the blood pressure increased by this amount, the risk doubles. And so if we have cardiovascular mortality on the y-axis and on the x-axis, we have increase in blood pressure. You can see that the cardiovascular mortality, dying from uh, cardiovascular disease, heart attack, strokes, increases as the blood pressure increase. And that was presented in the Lancet Journal in 2002 and the New England Journal as well. So we use what we call JNC, the Joint National Commission, um, to help us to make the diagnosis of hypertension, and it sort of guide us into treating hypertension. Well, we're going to look at JNC 7. Okay, I'm going to look at JNC 7 first, and then we'll discuss JNC 8. There's a JNC 8. So again, JNC stands for the Joint National Committee on Prevention, Detection, evaluation and treatment of high blood pressure. And the number just mean, you have JNC 1 to go straight up. So it tells you the most recent one. All right. So when you look at JNC 7, um, the goal is to the goal of the goal is to reduce cardiovascular and renal morbidity and mortality through the prevention and management of hypertension. So as I showed you previously, hypertension increases the risk for cardiovascular events. All right, that is your stroke, your heart attack, your peripheral artery disease, and renal disease as well. So if you look at JNC 7, they have a classification of blood pressure, and the different categories that we have normal, we have what we call pre-hypertension, stage 1 hypertension, and stage 2 hypertension. JNC 7 said that a normal blood pressure should be systolic less than 120 and diastolic less than 80. Pre-hypertension is individuals with systolic blood pressure between 120 and 139 and diastolic between 80 and 89. And then stage 1 hypertension, systolic between 140 and 159 or diastolic between 90 and 99. Then stage 2, those individuals with higher blood pressures, systolic greater than or equal to 160 and diastolic greater than or equal to 100. So this is how JNC 7 classify blood pressure. If you look at population-based strategy, when we, after intervention, this is after intervention, and then before the intervention, you can see that when we are aggressive, we can get blood pressure reduction, and blood pressure reduction results in reduced mortality, reduced death in patients with strokes and coronary artery disease, cardiovascular disease. So reduction in blood pressure will give you a reduction in cardiovascular mortality and morbidity as well. If, again, one of the studies that help us to understand the risk factor for coronary artery disease is the Framingham Heart study. Framingham is a city in Massachusetts, and they look at the people who are living there. So if you look at the impact of systolic blood pressure and the progression of coronary artery disease, that is, looking at the top number in the blood pressure and how it relates to the progression or the worsening of coronary artery disease. If you can look at the change in the atheroma volume, that is the plaques that is inside these vessels. If you look at the change in the plaques, okay, on the positive axis, then this is an increase, and then on the negative axis, it's actually a decrease in the size or the volume of the plaques. For normal individual patients who have no hypertension, you can see that there's actually a reduction. They don't have there's a greater reduction in plaque size, as opposed to our pre-hypertension individuals. And we show you the classification for those. The plaque change in atheroma plaque volume is modest. But when you look at your hypertensive individuals, there's a huge plaque burden. So again, one of the suggestion that hypertension is a risk factor for coronary artery disease. And then, if you look at the structure of the heart in hypertensive patients, and you were to follow them, uh, you hypertension give rise to injury to the cell. Then, okay, so it's one of the things. So, if you look at your risk factors, um, your risk factors will cause damage to the myocytes. And when you damage the heart muscle, you get what we call apoptosis, which is a programmed cell death. So the cell dies. So, as a matter of fact, any type of injury to the heart muscle cell, you get apoptosis, which is programmed cell death, and the cell dies, and you'll get fibrosis. You become fibrotic, and you can get hypertrophy. The cells increase in size. So we have shown that hypertension and the greater the blood pressure is a risk factor for coronary artery disease, and it increases cardiovascular mortality and morbidity. We also show that hypertension and progression of chronic kidney disease to end-stage renal disease is actually a real one. So that is, the greater the blood pressure, you'll get kidney damage, and these individuals will develop chronic kidney disease and end-stage renal disease. So there's an association of systolic and diastolic blood pressure with the risk of progressing to end-stage renal disease. So before they get to the end-stage renal disease, they develop some type of chronic kidney disease. Um, uh, and they have done studies to show this as well. Okay, so high systolic blood pressure accounts for most of the risk for progression to end-stage renal disease. Highest risk is in those with systolic blood pressure greater than 150 or greater than equal to 150 millimeters mercury. The risk was suggested to start at systolic blood pressure about 140 rather than 130. But the important point is that uh, hypertension, especially systolic hypertension, can cause chronic kidney disease and end-stage renal disease. So if you look at renal function versus death, cardiovascular events, or hospitalization endpoints, um, the rate of death from any cause, if you have kidney damage, and one of the things that we use to follow the degree of kidney damage is what we call GFR, glomerular filtration rate. So the lower the GFR, the worse the kidney injury. Okay, and then less than 15 is probably end stage kidney disease. So you can see that as the GFR decrease or the kidney function decrease, you get an increase in the rate of death from any cause. So patients with kidney damage have an increased mortality. We know that hypertension uh, uh, cause is one of the risk factors, or one of the cause for chronic kidney disease and end-stage renal disease. And then if you look in cardiovascular events, that is, heart attack, heart failure, stuff like that. As the kidney function deteriorates, that is, as the GFR gets lower and lower, your incidence or your rate of cardiovascular events increase. That is, your heart attack, your heart failure. Okay, so hypertension is a bad actor, essentially. So when you look in systolic blood pressure, and you know and you're going to treat it, how low should we go? What is the cutoff that we should sort of back off our medication? Now, if you look at this study. This is what we call the UKPDS 2000 trial. And if you look at tight blood pressure control, that is, we try to get the blood pressure as low as possible with tight control, and then less tight control. If we look at patients with events, and we, we on the y-axis we have events, and then on the x-axis we have its time. So you see, as time goes on, the tight control tend to have less events. So it is probably best to treat these individuals to a lower blood pressure, because you see the tight, when you have tight control of the blood pressure, that is lower blood pressure, and in this case it was systolic blood pressure. When you get the systolic blood pressure fairly low, you have decreased events. That is, you have decreased heart attacks, you have decreased strokes, things like that, as compared to the less tight control. Okay. So again, your heart attack and stuff like that decrease with the tight control. So what they have shown is that the effects of intensive blood pressure control is a good one. So that is, try to get the blood pressure as low as possible. But what about the effects of intensive blood pressure control in patients with diabetes? There's a study they call the ACCORD study. They close to about 5,000 patients with type 2 diabetes, and they compared systolic blood pressure, treating to systolic blood pressure less than 120 or 140. The primary endpoints was what we call non-fatal heart attacks, non-fatal MIs, or non-fatal strokes, or cardiovascular death. So these are the endpoints. The patients on treatment so we have two groups then. So they try to get the systolic blood pressure below 120 and below 140. So we call this group the intensive group. So we try to get we try intensive management to try and get the systolic blood pressure down. So this group, the systolic blood pressure, they reduce it to below 119 millimeters mercury. This is the intensive group, versus the less intensive group, where the systolic blood pressure, they try to get it below 140. You got it to about 133. And as mentioned before, the JNC, when we look at JNC 7, the guidelines suggest that we should treat blood pressure in diabetics systolic less than 130. So the JNC 7 recommendation is that if you're a diabetic, you should get the systolic blood pressure below 130. That's a recommendation. But what the ACCORD primary and secondary outcomes showed is that for the intensive group, that is, try to get the systolic blood pressure below 119. For this intensive group, the total mortality was 1, okay, compared to the standard group, which is about 144. But when you look at the percentage, when you look at the percent per year, it was 1.28 in the intensive group, and it was 1.19 in the standard group. This is total mortality. So you see, in the diabetic patients, we actually get more mortality by this intensive management, getting the systolic blood pressure below 119. If you look at cardiovascular death, that is death from heart attack, heart failure, stuff like that, the percentage per year was actually greater in the intensive treatment group as compared to the standard treatment group. Non-fatal heart attacks was a little bit lower in the intensive group compared to the standard group. Non-fatal stroke was a little lower in intensive treatment group. And if you look at total stroke was also lower in the intensive treatment group as compared to the standard group. But this was a bit disappointing to a lot of us because we thought that, intensive blood pressure management in diabetics would result in a reduction in total mortality, but we actually have a slight increase as compared to standard, and then cardiovascular deaths, it was about the same. So we didn't see the benefit for intensive blood pressure management in type 2 diabetic in the ACCORD trial. So the ACCORD conclusion was that, so again, the ACCORD BP trial evaluated a target in a systolic blood pressure of 120. So that's the intensive group, which they tried to get a systolic blood pressure below 120 millimeters mercury, compared to a goal of 140. So the less intensive group, 140, in patients with type 2 diabetes. So there was actually an increase in cardiovascular risk. The number needed to treat to prevent one stroke was 89 over a 5-year period. There's a trial called the HOT trial, and as we showed it before, the UK PDS trial, it showed low events in intensive treated groups, but the systolic blood pressure was 144 in both trials. So the systolic blood pressure is not as low as in the ACCORD trial. So the ACCORD trial results provide no conclusive evidence that the intensive blood pressure control strategy reduces the rate of a composite of major cardiovascular events in such patients. So what they're saying is that the ACCORD trial didn't show the benefit in reducing systolic blood pressure, at least below 120. Possible that most of the benefit from lowering systolic blood pressure is achieved by targeting a goal of less than 140. So they say, getting a systolic below 140 is probably okay. So secondary analysis of the ACCORD trial showed that the harm had comparison of standard and intensive glycemic control and lipid treatment in the same trial. So they were also doing glucose control and lipid control. As compared with the standard glycemic and blood pressure treatments, the intensive blood pressure treatment alone reduced major cardiovascular outcomes by 26% without additional benefit from combining the two treatments. So if you just single out if you look at if you single out just the blood pressure and not look at the glucose control and lipid control, then so there's another trial called the INVEST trial, which is the International Verapamil SR Triandalopril study. And this is an observational group analysis of about 6,000 plus patients. These are individuals greater than or equal to 50 years old with diabetes and coronary artery disease. So these are older individuals, a little bit older individuals with diabetes and coronary artery disease. And they had a tight control. So the tight control are able to maintain a systolic blood pressure below 130. So this tight, as opposed to the ACCORD trial where the tight control is, they try to get a systolic blood pressure below 120. In the INVEST trial, the tight control try to get the systolic blood pressure below 130. The usual control is between 130. So this is another group. Okay, so one group that tight control systolic below 130. One group systolic between 130 and 140, and then the other group, the uncontrolled group, greater than or equal to 140. So the conclusion from the INVEST trial that tight control of systolic blood pressure among patients with diabetes and coronary artery disease was not associated with improved cardiovascular outcomes compared with usual control. So this is similar to what the ACCORD trial showed us. So that, tight control, aggressively trying to get the systolic blood pressure down, it was not associated with an improved cardiovascular outcome. And, this is a 6,000 plus patient. So, again, the JNC7 recommend just try and get in the systolic blood pressure for diabetics below 130, not the tight control. If you look at the IVET trial, which is hypertension in the very elderly, these are patients over 80. So these are patients over age 80, and they have to have a systolic blood pressure greater than 160. So the primary endpoint in this IVET trial was fatal or non-fatal strokes. And they treated the patients with indapamide, which is a blood pressure, one of the blood pressure medicines we have. Indapamide 1.5 plus or minus perindopril. So the treated group got indapamide plus or minus perindopril versus placebo. Okay. The perindopril was 2 or 4 milligram added for systolic blood pressure less than 150. So you have older individuals. Again, the outcome you're looking for is strokes, fatal or non-fatal strokes, and the treated group got indapamide and or perindopril. So what they found in the HIVET trial, if you look at blood pressure and follow-up in years, so again, the placebo group is in blue, the treated group is in orange. So you can see that the placebo group, as expected, tend to have higher blood pressure as compared to the treated group. So they are getting medication, so you expect the blood pressure to be less, systolic blood pressure. The mean follow-up was 1.8 years. And so and of course, so their diastolic and systolic pressure was lower. And again, this is what you expect because they're treated. If you look at all strokes, okay, 30% reduction. So the placebo, and this is the number of events per 100 patients and follow-up in years. So the placebo group with a higher blood pressure tend to have more events compared to the active treated group. They had less events. And again, remember the HIVET is in older patients over age 80 with systolic blood pressure greater than 160. So this study showed that if you treat them and get the blood pressure down, they tend to have a reduction in fatal and non-fatal strokes. So this is the IVET trial. And then total mortality, again, was also lower in the active treatment group as compared to the placebo group. Fatal stroke was also lower. Heart failure was also lower in the treated group. Again, remember, these are older individuals, age 80. So the conclusions from the HIVET trial is that antihypertensive treatment based on indapamide, and they use the slow release, 1.5 plus or minus perindopril reduce stroke mortality, total mortality in a very elderly population. Okay, the number needed to treat over 2 years is about 40 for mortality. So you have a large and significant benefit in reduction of heart failure events and for combined endpoints of cardiovascular events. So the conclusion from the HIVET is that older individual with significant systolic blood pressure should be treated. Okay, um, the benefits were seen early. The results support a blood pressure target of about 150 over 80 in patients getting treatment. So you're gonna treat, uh, this is your target, 150 over 80. So that was JNC7. Now we're going to look at we're going to look at some features of JNC8. And the reason why we do it like this is because there's a lot of problems with JNC8. Okay? There are some groups who do not use JNC8 at all. And one of the questions that we'll ask is, among adults with hypertension, does initiating antihypertensive pharmacologic therapy at specific blood pressure threshold improve outcomes? So, what is the threshold? When should we initiate drug treatment? All right. What is the level that we should start medication? And then question 2, among adults, does treatment with antihypertensive pharmacologic therapy to a specific blood pressure goal lead to improvement in health outcomes? That is, how low should we go? We show that in the ACCORD trial, we show that reducing when we have intensive treatment for blood pressure, we actually had increased mortality in that group. So how low should we go? And then question 3, in adults with hypertension, do various antihypertensive drugs or drug class differ in comparative benefits and harms to a specific health outcomes? That is, how do we get there? What medication should we use? So the problem, well, this is what JNC 8 members advise. This is what JNC 8 says. Okay, we went over JNC 7, Joint National Committee. We with JNC 7, they had normal, they had pre-hypertension, they had stage 1 hypertension and stage 2 hypertension. So JNC 8 says that if you're over age 60, you should treat this is when you should initiate therapy. If the systolic is greater than 150 or diastolic greater than 90. So you want to treat to below this number. So over age 60, you want to treat to get the number below 150/90. They say that less than 140/90 is okay if the individual tolerates it well. So, and a lot of people have problem with this value. They think it's too high. Okay, so, but this is what JNC 8 states. Okay, you're gonna treat the blood pressure if it's greater than 150/90. Everybody else, so if you're younger than 60, you should treat to a blood pressure of 140/90. So what they're saying, if you're older then you can don't be as aggressive. Then you can accept a little higher blood pressure. But for everybody else, you're going to treat uh, to reduce the pressure to 140/90. And JNC8 recommend a simple drug strategy. Any of the four choices you can use to treat your hypertension: ACE inhibitors, ARBs, calcium channel blockers, and diuretics. Okay, so any of these four you can use. Uh, so you can relax the targets in elderly patients. If the patient is on the 60 with diabetes and chronic kidney disease, you can relax the targets. They say for blacks, you can start thiazide or calcium channel blockers. And if the patient is older than 18 with chronic kidney disease, um, you can initial or add-on treatment should be you can use an ACE inhibitor, HARB, which is angiotensin receptor blocker, regardless of risk. But the important thing is that they do not recommend starting beta blockers. Okay, so if you look at any of the four choices, beta blockers are not there. So they recommend ACE inhibitors, HARB, angiotensin receptor blockers, calcium channel blockers, diuretics. Okay, and for blacks, thiazide, or calcium channel blockers. So this is the JNC8. So we know that blood pressure and risk are linearly related. Randomized controlled trials have found that lowering blood pressure as little as 10 millimeters mercury in patients with hypertension can reduce lifetime risk for cardiovascular and stroke death by 25 to 40%. We showed that before. So the prior guidelines use the totality of evidence. They use the randomized controlled trial, meta-analysis, observational studies, also expert opinion. Since the risk rises rapidly with systolic blood pressure greater than 140, shouldn't we be more aggressive? As we look at the IVET trial. The IVET trial, tells us that for all the patients we should get that systolic blood pressure down. All right. JNC8 also recommend what we call a DASH diet with salt restriction. So they recommend salt restriction. You should consume less than 2,400 milligrams of sodium per day, limiting your intake to less than 1,500 milligram can result in even much better blood pressure control. So salt restriction is very important in management of hypertension. Physical activity, 3 to 4 sessions per week, and each session should be about 40 minutes. Okay, try to maintain healthy weight. Know your ideal weight. And JNC8 didn't mention anything on alcohol intake. So as I said, there are some problem with JNC8. So some groups took exception to the higher target for the individual 60 and above. So this is a bone of contention. Some groups think that this target should be much less than 150/90. Concern reduce the intensity of treatment. A large proportion of patients have this type. So what they're saying, if you allow patients to walk around with this pressure, we know that hypertension is a risk factor for cardiovascular disease, and not only a risk factor, but the higher the pressure, the greater the more mortality and morbidity then these patients going to do poorly. Um, so the evidence is insufficient and inconsistent in patients age 60 or older. So JNC8, there's a lot of problems with JNC8. There's a large group who just revert back to JNC7 because of the laxity of JNC8. We know that SHEP and IVET found a benefit of treating older patients with systolic hypertension. Um, so, you know, so a lot of people do not follow JNC8. Um, all right. If you look at the SPRINT trial, okay, the SPRINT trial look at individuals, individual 50 years and older. So to be included in the trial, you have to be older than 50, systolic blood pressure between 130 and 180. You have to have additional cardiovascular risk, such as, you know, uh, you may have a stroke, but that exclude you, okay? Chronic kidney disease with a GFR between 20 and 60, and the Framnum Ritz score. Um, so any one of these will include you will be included in the study. Um, or if you're age greater than 75. You're excluded if you had a stroke, diabetes, uh, uh, chronic kidney disease, heart failure, proteinuria, um, adherence concerns. So this is a SPRINT trial, and what the SPRINT trial show that blood pressure reduction in these older individuals. This is the intensive. So we have an intensive treatment group, standard treatment group, and you can see that the systolic blood pressure is much lower in the intensive treatment group, which is what you expect if you're going to treat the blood pressure aggressively. So the result from the SPRINT trial shows that at 1 year, the mean systolic blood pressure was 121 in the intensive treatment group and 136 in the standard treatment group. The mean follow-up was about 3.26 years. The study was stopped early because of lower rate of primary composite endpoint, such as MI, acute coronary syndrome, stroke, heart failure, death from cardiovascular causes, and you had lower all-cause mortality. Okay, so this is another study that showed that intensive treatment uh, reduce, your cardiovascular events. Uh, However, there had some increase in serious adverse events from hypertension because you're treating these patients aggressively. So, um, when the blood pressure gets pretty low, patients pass out, you have syncope, you have electrolyte abnormality, acute kidney injury, uh, but not injurious falls. So the SPRINT trial conclusions. Among patients at high risk of cardiovascular events, but without diabetes, so this SPRINT did not include diabetes, targeting a systolic blood pressure less than 120 versus one less than 140 resulted in lower rates of fatal and non-fatal major cardiovascular events and death from any cause, although significant higher rates of adverse events because of the lower pressure. Uh, patient pass out, they had electrolyte abnormalities, stuff like that. Separation and mortality was a part, so you had to treat them for 2 years to see, a reduction in mortality. The relative risk of death from cardiovascular causes was 43% lower with the intensive treatment group. Heart failure, 38% relative risk reduction. The number needed to treat is 61. So they did not include diabetic in these patients. So, which is different from the ACCORD trial where it was diabetic patients. So should we not be very aggressive in diabetics in terms of blood pressure reduction? So it's possible not applicable to diabetics or patients with prior strokes. And they did not look at patient less than 50. Okay. Way better outcomes with respect to cardiovascular events and death versus more adverse events, including hypertension. So again, even though you had improvement in cardiovascular events, patients tend to be, they had a lot of hypotension, syncope, and some renal impairment. Lower target requires more medication because you're treating these patients aggressively, so they use more medication and more likely more visit to the doctor's office. The group had an average cardiovascular risk of approximately 2% per year, equivalent to the phenomenon 10-year cardiovascular risk of approximately 20%. So the SPRINT trial was pretty impressive again, but it did not include diabetics. Blood pressure measurement. So it's important how you check the blood pressure, and even when the patient come to visit you, you have to be careful how you do blood pressure measurements. They actually, in the SPRINT trial, they actually did an average of 3 office visit readings before they, say whether the patient is hypertensive, yes or no. You have to use the proper cuff size, so that's very important. They did seated measurement. The patient had to sit down, 5 minutes of rest before they measure the pressure. No conversation during the rest period or blood pressure determination. And they used the Omron automated manometer. They think the blood pressure done in this way likely overestimate blood pressure and overtreatment test. So there's problem with JNC 8 in that they allow higher blood pressures in older individuals. So that's one of the concerns. And as mentioned before, beta blockers are not one of the starting medications for the treatment of hypertension. So hypertension is very, very common. It's a major risk factor in our cardiovascular disease, renal disease. So treating blood pressure and treating it adequately is important. You have to know which medication to use. Some medication can actually cause harm, so it's important to choose the appropriate medicine then. And remember that the beta blockers are not one of the first line for treating hypertension. All right, so